And so some of the main components that we pay a lot of attention to with patient education, let me just cover some of the main components right now that are vital to patient education and the market and how the market responds and acts. And so, one of the big ones is the four-step cycle. That's a major concept that we buy products and services in a four-step cycle. It's really unconscious. It's not conscious, it's subconscious. It's needs analysis. Do we have a need for that product or service? Presentation. What information do we have to help solve that particular problem? Obstacles, any obstacles, and close. That's the four-step cycle of how we buy products and services. Even if it's a Snicker bar at the counter, we'll go through them faster. In a home, it'll take 9 months, but we will still go through those four steps. Now, the reason that's important is that's what we did with the patient education is we put them into four steps, essentially. We put it into the four-step sales cycle. That's why it's 4 days. That's one of the main reasons it's 4 days. There's a lot of other reasons, but that's one of the main reasons it's a four-step cycle, okay? And you'll see that. Day one, we'll do the consultation, examination, and some therapy to help start relieving some pain. Day two, we'll start treating them, ask for 3 days. And then day 3 and then 4, we'll actually do the report of findings. So that's a major concept. You never want to violate the natural purchase pattern of a consumer. You're already on the wrong road as soon as you do that. I always say you're better off if, like doctors that do a 2-day report, they would have way more success if they took that 2-day report and divided it and spread it out into 4 days alone for a few reasons. So a second reason is the byproduct of trust and confidence and defenses and resistance. So when we go into 4 days, the trust and confidence goes up. That's a natural byproduct of multiple contacts. That is used in marketing for a lot of different ways, whether it's a marketing campaign, patient education, and it's the byproduct of multiple contacts. And what happens is each time there's a contact, the trust goes up. Naturally, the trust and confidence naturally goes up. Defense and resistances naturally go down. So once again, if the doctors just did, instead of a 2-day, did a 4-day, they'd have more success because the patient would have more trust and confidence at the end of 4 days than 2 days. And what's interesting about that concept, the second day carries the greatest weight. You have the biggest bump of trust and confidence between the second and third day. So again, doctors that are only doing a 2-day report lose out on all of that, all these natural phenomena that help. So we're going to pay attention to that. And probably the single greatest concept of patient education is that the patient is, first of all, understanding market forces, and that the less you do, the more you get market forces. Well, what are natural market forces? Patients don't want to stay, pay, and refer. Patients don't wake up in the morning going, man, I can't wait to drive, 22 minutes to the chiropractor's office, be in his office for 20 to 30 minutes, and then drive another 22 minutes home. And I want to do that 3 times a week, and I want to pay $50 to $100 every time I do it. They don't wake up like that. None of us would want to do any of that. So the less that you do with patient education, that's what you get. You get market forces. And they base their care on how they feel. That's all they know. For however old they are. If they're 40 years old, they base their care on, how their symptoms. And of course, the symptoms are the first component to start getting better out of all the different tests. So one of the major components of patient education is to get the patient to shift their consciousness level to base their care on the tests, on all the tests, not just one of the tests. That's a major concept. And if you just allow them to base it on how they feel, they'll be in for a few visits and gone. and you won't be affecting them at all. And then another major concept is its care that's based on the science of the three phases of healing. And to be honest with you, that alone is the reason to do it. If you didn't even care about any of the other, business reasons or the real reason that care is the science of the three phases of healing. In other words, how we heal. So that alone should be the reason why doctors that are doing physical medicine should base their care on the science of the three phases of healing. So we know that the inflammation phase is the first 72 hours, and then you have the repair phase. And of course, the goal there, the therapeutic goal, physiologically, is to decrease pain and inflammation and muscle spasms. That's the therapeutic goal. And then the second phase of healing, the physiology, is to increase active, passive, and joint motion. And then that's the goal of the therapy. And then the goal of the therapy in the remodel phase is to increase the strength and elasticity of the tissue. And the reason we do that is because of what's happening physiologically with the tissue. Anytime we have inflammation, pain, and it's usually the origin of major trauma or minor trauma. That's how we get patients. 90+% of the reason patients come to us is from either a re-injury of a pre-existing trauma or repetitive minor traumas. And then the top three symptoms patients come to us for are pain, muscle spasms, and restricted mobility. That's the three symptoms they come to us for. And then the main reason they come to us is because it's causing pain and restrictions with their activities of daily living. That's the number one reason patients spend time or money, is because they're having pain and restrictions with their activities of daily living, something that's really important to them. Now that gets to be real important. Knowing all these basic concepts and putting them together gets to be real important. So we also know that in the inflammation phase, and so that's what we're trying to do therapeutically, and we need to be able to explain it to the patient. And we need to be able to explain it very simply. So, and we cannot overwhelm the patient. We can't do that. You can't give them a ton of information on day one. And I couldn't just dump all this into day one. That alone, besides violating, the sales process and how we buy it down, all that alone would just be way overwhelming. So we have to stair step the information. And so that's why we just stair step it on day one. We stair step, patient education for day one, for the repair phase, day two, and day three, the remodel phase. So these are all major concepts relative to patient education and why we do what we do, why we put them in the way we do. And then, of course, another big concept is how patients want the questions patients want answered. They want answered the four big questions. What's my problem? Can you help? How long is it going to take to feel better? How much does it cost? They want to know that. Okay. So we need to honor that. We need to respect it and honor that and deliver the information accordingly. In other words, we don't want to jumble that around. We don't want to go into cost first and then go into what's your problem, or, that we're totally violating naturally how we buy things. In other words, when I go somewhere, if I go to a doctor, a dentist, an optometrist, whoever, that's what I want to know. And that's the order that I want to know it. And a lot of times it's subconscious. It's not even conscious. Now, if you don't cover it, it'll get conscious and they'll realize you didn't cover it. Okay. But these are major, major concepts. And I talked about the third party biomarker. We want them to put their care into the test, to determine the test. I say it all the time, what kind of doctor would you be if somebody came in with cancer and they had the symptoms of cancer, and you did the cancer treatment, and symptoms were gone. But all the other tests, all the other cancer biomarkers were positive. You going to let the patient go now? Or they are. So now that's just a little bit of an example. So when we do the 3 phases of healing, that's, from a ethical standpoint, a moral standpoint, a clinical standpoint, that's the goal, is to decrease the pain and inflammation and muscle spasms as fast as possible. That's the inflammatory phase. And then from there, increase the active, passive, and joint motion, and then the strength. And the reason is because the physiology, that's what's happening physiologically to the patient. They're initially having, pain and inflammation and muscle spasms secondary to the pain and inflammation. And then, of course, we pay attention to the nerves. What happens to the nerves? Well, the nerves come in, and one aspect of the nerves is there's hyperinnervation, reinnervation. Means there's an increased number of nerves in that area. That's a source of pain if that's not helped or corrected to some degree. The nerves come in and they can get trapped in the scar tissue. That's another source of pain. As a matter of fact, that's the number one reason for Feldback surgery syndrome, is the scar tissue, is the nerves that are the regenerative nerves that are getting trapped in the scar tissue. That's why they're constantly trying to make the incision smaller and smaller and smaller and smaller. In other words, this is real stuff. And then, so you have hyperinnervation, reinnervation, you have the nerves potentially getting trapped. The nerves fire at a lower level. So we're trying to do physical medicine to also decrease the nerves from firing at a lower level. Those are sources of pain. We don't pay attention to psychogenic pain. Psychogenic pain is like the phantom arm theory, when you get your arm cut off or whatever. That's not relative to the conversation here. So we'll pay attention to that. These are all, and then what's another source of pain is the pH of the tissue. That's why inflammation, that's why we try to decrease inflammation, is because the altered pH fires the nerves. That's a source of pain. That's why we're trying to control and minimize the inflammation as fast as possible. And then, of course, then there's direct damage to the nerve. Those are essentially the 6 sources of nerve pain. And that's what we're trying to affect and impact therapeutically. And then when there is this injury, whether it's a micro injury, and remember, it happens, you're either born with an issue, okay? Now, when you're born with it genetically, we can't do anything for it. Now that person just needs symptom care, and that's it. Like if somebody has a sacralization that's causing altered spinal biomechanics and back pain, that's it. They're born with it. All we're going to do is treat them palliatively. That's it. Okay. Or it's from major trauma or minor trauma. And that's what we see. That's what chiropractors see, man. Most of our patients are re-exacerbations of old injuries. That's what most of them are really from. And it's from major trauma and minor trauma that are causing the pain and inflammation, et cetera. So that's what we're trying to do therapeutically. Now, so how's this impact the patient? Well, it helps decrease their pain. That's good. It helps increase their mobility when you apply physical medicine to increase their active, passive, and joint motion. Because remember, there's 3 ranges of motion. And the most important motion is the paraphysiological joint space motion. Why? Because that's the fulcrum. That's the fulcrum of all motion of all joints. That's why it's the most important. That's the chiropractic adjustment. And then you also have that there's a type 3 collagen that comes in the heel. So we're born with type 1, type 3 comes in the heel. And type 3 is not as elastic, and it's not as mobile. It's not as mobile. So what does that mean to the patient if they heal wrong? It means they'll heal wrong with stiffness. That's what it means. And then, and these stiffnesses add up. Sometimes the little stiffness is what we call subthreshold. It doesn't affect sensory motor, but it's still there. Because remember, we will never heal 100% ever. Anytime you have an injury, it never goes back to 100%. What it does, and what we try to do, is to get it sub-threshold. In other words, where it's not affecting sensory and motor, active, passive, joint range of motion. In other words, you can do all your functions with no inhibitions. But it'll still be sub-threshold. It'll still be there. It'll never be back. And that's what happens with regular injuries. It's one injury on top of another that just get layered, essentially, that eventually it starts to be getting above threshold. And that's when patients, start having stiffness, rigidity, lack of strength in that area. Then the lack of strength causes re-exacerbations. That's why people re-injure themselves. And because that collagen is only 70% as strong. It's only that type 3 collagen is only 70% as strong. It's only 70% as elastic. Now you can go to the research articles and it may say 68%, 65%, 85%. We just make it simple. We're just communicating simplicity. So we're taking all these concepts and we're just trying to deliver them simply. That's all we're doing. We cannot confuse patients. So this is why, we're doing the physical medicine to affect not only the nerves, the neurology, the type 3 collagen matrix, but also the strength and elasticity. That's why we'll do some strengthening or we'll do some elasticity. And the whole goal through all these 3 phases is to decrease their pain and inflammation and muscle spasms, decrease any pain that's above threshold, and increase the tissue strength so there's not re-exacerbations and permanent problems, and increase the mobility and the elasticity of the tissue as much as possible. And that's the whole goal therapeutically, is try to minimize all these natural effects that are happening that causes pain and restrictions with patients' activities of daily living. In other words, permanent problems to some degree. That's what we're trying to do. And sometimes we can only decrease the magnitude of the permanent problem. That's it. In other words, instead of it being significantly worse, now it's not as bad, but it's still permanent. See, so sometimes that's the case. But of course, the overall therapeutic goal is to get it subthreshold to where the patient has no pain or restrictions or muscle spasms in all 3 ranges of motion. And this is vital, not just active range of motion, all 3 ranges of motion, and increase the tissue tensile strength because we already know it's not as strong, and increase the tissue's mobility because type 3 collagen is not as strong and it's not as mobile. So that's what we're trying to do therapeutically. Okay, and then we're doing the test. When we evaluate the patient, we're doing all the diagnostics to see what the problem is and to quantify the problem. And then when we do our therapeutics, that's essentially the goal of physical medicine. The goal in the inflammatory phase from either major trauma or minor trauma is decrease pain, inflammation, and muscle spasms. The goal as the physiology continues, and now the repair phase starts to happen. And by the way, how much does this happen? Does this not happen when there's only 5 cells involved or 10 cells? In other words, does the 3 phases of healing only occur after there's a minimum of 1,000 cells involved? No. It happens from the very first cell that's damaged. This happens from the very first cell. Now, the question clinically is, how much does it affect that person with their pain, muscle spasms, range of motion, and all of those affect their activities of daily living? That's the clinical question. Okay. So these are the main concepts we're paying attention to. So we got a lot of things to integrate here, to give a good service. So I can only pay attention to the clinical part and not be a good communicator. And I'll destroy the relationship just because I'm a bad communicator. So you could be great clinically and violate basic principles of communication, and you'll lose the patient anyway. You might be a good communicator, but now you don't know the science of the 3 phases of healing. And so now you're just treating the patient for just a couple of the biomarkers. You're only just treating for symptoms and inflammation and gross range of motion. That's it. Let's say, well, now you're leaving all these other biomarkers positive to heal wrong to some degree. Now, whether they're going to heal above or below the threshold, that remains to be seen. But eventually, when you get enough of these micro traumas, eventually they become major traumas. They start healing above the threshold more and more and more and more. In other words, people start losing more and more and more range of motion. They start having more and more pain associated with that loss of range of motion. And it starts to get worse and worse and worse. That's what happens as these problems continue to progress or layer on one another. So sometimes, we can't help these people 100%. We're just trying to minimize this layer of adding on to the problem. That's all. Now, if it's already above threshold, in other words, they already know it's permanent, then our goal is to just try to decrease the degree of permanency. We already know it's permanent. So let's say, as an example, above threshold is, say, 20%, and they're already at 40%. Well, we're just trying to keep it down around 40%, 41, 42%, instead of it being 60% or 80%. Say, that's how. So everybody still goes through the science of the 3 phases healing, even if they had a permanent problem with that problem when they came in. That new tissue, so the old tissue is still there, it's permanent. Well, now we have new tissue that's now going through those phases. And so that's why I say a patient can come in and be in all 4 stages of healing. They could come in with a previous permanent problem. You're not going to be able to affect that. And they could come in with and they could be in the inflammatory phase with a new major or minor trauma. Or they could come in with those 2, and they had an injury prior to that that's now in the repair phase. So you could have a patient come in that has permanent problems. They have new tissue that's in the inflammatory phase from a recent exacerbation. And then some of that tissue is still is in the repair phase because it happened, maybe a month ago. And that is the timeline of the physiology, by the way, is the first 72 hours is the inflammatory phase. From 72 hours, from 6 to 12 weeks is the repair phase. Now, does it heal on the 4th day, 5th day, and 6th day? Yes. Can there be inflammation on the 5th day, 6th day, 7th day? Yes. So these are not black and white corridors. They overlap. And of course, your goal is to go, okay, we got to start therapeutically with the pain and inflammation phase, even though, say, the patient is in all phases. They came in with a permanent problem. They have new tissue that's been irritated. They have tissue that they irritated and inflamed a month ago or 2 months ago that's in the repair phase. And they have tissue that's in the remodel phase that was injured 6 months ago. So they have all spectrums of tissue. And that's the norm. Normally there's overlap. That's the way it is. You always have to start with the inflammatory phase, though. And then from there, decrease pain and inflammation. From there, go to ranges of motion, active passive. Then from there, increase tissue. So even though they had the permanent problem, we're still trying to minimize layers of permanency. That's what's happening physiologically in a really simplistic manner. That's what we're doing chiropractically. And it's a very important function, not only because of the patient, the quality of life of the patient where they don't have pain and inflammation and muscle spasms. That represents a huge quality of life factor, but also when the patient has mobility, when they can be able to move with active, passive, and joint motion, with doing their activities of daily living, like work. Work's not an activity of daily living, but people need to work for survival. When they can work, when they can sleep, bathe, shower, dress, those are huge quality of life factors. And that if you lose them and you start losing them to different degrees, that's worth not having. And there's a lot of people that would pay a lot of money that are already in permanent problems, that would pay the money to not have those layers of permanent problems later in life. So we're talking about quality of life issues here. So, and then of course, how it affects your range of motion, not just with sleeping, bathing, showering. You go into cooking, cleaning, laundry, landscaping, house maintenance, gardening, things that are important to people. That, some of these factors are necessary for survival. Cooking, is feeding yourself. That's a, personal hygiene, being able to take care of yourself. These are important things. So chiropractic is a major player. And so when you look at the 3 phases of healing, you go, okay, and you compare it to other fields. You go, okay, we got the inflammatory, whether it happened from major trauma, minor trauma, whatever, and then you got the pain and inflammation, muscle spasms. Well, chiropractic, the benefits for chiropractic is we'll use therapeutics in that phase that are non-invasive. There's no side effects when we use chiropractic, or we use like laser therapy, cold laser therapy, or we use passive motion therapy, or whether there's ice packs or bowel freeze, or whether we're using muscle stim, Russian stim, interferential current. See, all these different therapies help with pain and inflammation, muscle spasms, but there's no side effects. So that's the benefit. Where if you were to compare it to, say, like medicine, let's compare it to like medical doctor. Well, they would just give, anti-inflammatories, pain pills. Okay. And those are fine too, if they're not taken very long, but they definitely have side effects. Every synthetic medication has a side effect, and usually they're not very good. That's like aspirin's responsible for 20% of kidney disease, kidney failure, aspirin. Ibuprofen's responsible for a lot of ulcers. So there's a lot of side effects going on here. And then if you take non-steroidal anti-inflammatories for any length of time, especially during the repair phase of healing, it inhibits collagen synthesis. In other words, the healing tissue, it inhibits it from healing. What does that mean? It means that tissue is going to permanently heal weak, wrong and weak the rest of that person's life. That's what, you combine NSAIDs through the 3 phases of healing with no physical medicine and active passive joint motion. You just essentially led to the #1 disability in the United States, osteoarthritis. So people, and that's what happens is people have these traumas. The most common thing, they typically don't get physical medicine. 2% of the population never goes to a chiropractor. So they'll take their pain pills and medication. So now they're typically on their NSAIDs, which is inhibiting, collagen synthesis during the most important time of healing, the repair phase of healing. And they're not, you combine that with, they're not getting physical medicine to affect the type 3 collagen in the alignment and strength. There you go. And then you take that to the next stage where you have decreased strength and elasticity that was not affected therapeutically. You now have pain. You now have restrictions, pain, and loss of strength in different areas of your life with your activities of daily living. And that's what's happened to the masses. That's why one in five of the population has osteoarthritis. Arthritis is the number one disability in the United States. 1 in 5 people have osteoarthritis. Of the arthrotypes, osteoarthritis is the number one disability of arthritis. And how did it happen? Well, it all happens when the patient doesn't receive the right care for the pain inflammation, but that's not as important there. But now when you do not receive physical medicine in all 3 ranges of motion, active, passive, and joint motion, especially the joint motion, that's what causes altered kinematics. The joints move abnormally. And then it becomes permanent. It heals like cement, and it's wrong. Those micro traumas they just continue to get worse with the patient as the patient moves every day. And how does it start to affect all the tissues? Cartilage starts wearing it out fast. Ligaments increases the thickness of the ligaments, laxity. Tendons overstresses the tendons, thickness of the tendons. Nerve tissue, it can damage the nerve tissue directly. Vascular tissue, arteries, microarteries, damage to microarteries. All of these, proprioception affects the proprioception of the joint and how people move and feel. All of these things now start at a very micro level. And where did it all start? It all started with altered joint biomechanics. Where did it start prior to that? Major minor trauma. So the patient has the major minor trauma in America, and what do? They take their NSAIDs. They don't know any better. They take their ibuprofen, Motrin, aspirin, all that, or they go to the doctor and they get their pain medication. Well, in the inflammatory phase, that's not going to be as big of a deal because it's number one, it's short term, so you're not going to have the side effects as fast. But now they continue on into the repair phase, and now you got some serious problems that are starting to happen now. Not only is the collagen not being synthesized, the type 3 healing collagen, and it's healing wrong in an abnormal matrix, which compresses the nerve fibers prematurely with tensile or compressive forces of movement. This is all these sources of pain start to get ignited. And then combine that with no physical medicine to align the collagen, the type 3 collagen, to decrease the likelihood of those peripheral nerve findings getting trapped in that matrix and decreasing the nerve decreasing the nerve sensitivity, which both of those decreases the likelihood of pain with movement. You're headed for disaster. You're headed for a definite permanent problem. So now you go to the third phase. So when you have those two combinations in the repair phase, and that's what most of America is getting, now the patient moves into the remodel phase, or the remodel phase. Well, now the healing becomes permanent. There's no more synthesis. That's the repair phase. And so if that tissue is not stressed with resistance to increase the tissue strength or mobility therapeutically, now that patient heals wrong permanently to whatever level that was. What does that mean to the patient? It means pain with movement. It means pain with restricted activities of daily living to some degree. It means high potential for re-exacerbations just because the tissue's not as, that anatomy is not as strong as with the type 3 collagen as prior to the micro trauma of type 1, normal type 1 collagen. And it's not as mobile. And we know these things as chiropractors. We see them all the time, and they're called fixations. Chiropractic, we evaluate a patient and we'll see fixations, and we already know that was micro or macro trauma. years ago that healed wrong. It's always tender, it's painful, causes other symptoms too, decreases range of motion. And then how much of these, whether it's major trauma to some degree, or a lot of micro traumas that add up, there you go. Now we have a permanent problem to some degree with this patient the rest of their life. Most of them don't even know it. They haven't been taught that. Most of them would pick the right choices if they were taught that this is what happens here. You know, if all the patients knew you could take these medications for the pain and inflammation and muscle spasms, here's the side effects, or you could have these therapeutics with no side effects. Most patients would go, yeah, I want the one with no side effects, but they don't know. And then you go to the repair phase when there's the collagen synthesis. Most patients, if they knew what was happening, they would go, well, wait a minute. I don't want to keep taking these NSAIDs and these medication because now it's inhibiting collagen synthesis, and it's actually inhibiting the healing process, number one. And on top of that, I need physical medicine in all three ranges of motion, specifically and especially in the paraphysiological joint space motion, because that has the greatest impact with Wolff's Law with bone, Hodges' Law with soft tissue, with the piezoelectric effect to help reducing pain. See, all of these are laws, physiological laws, the piezoelectric effect, gate theory. Those are principles of physical medicine relative to helping pain. Same with Wolff's Law or Hodges' Law with bone and soft tissue, reformation, deformation of bone and soft tissue relative to the piezoelectric effect. That's what's happening. Would most patients, if they knew and it was affordable, would they go, yeah, I don't want to take these medications because of the side effects, but I not only that, and it inhibiting my healing, not only that, I want physical medicine in all three ranges of motion to affect nerve sensitivity, to help decrease nerve sensitivity, to help decrease the hyperinnervation, reinnervation of the nerves within the tissue, regenerative tissue, to help decrease the likelihood of those nerve endings getting trapped in the collagen matrix. All of these are sources of pain, to help decrease the pain and inflammation. See, would most patients say that if they knew it? Would they go, yeah, I'd rather, yeah, it's common sense. When you know it, it's like, yeah, why would I take something that's harming me and not get something that's going to help me? In other words, you're doing 180 degrees the opposite to create a permanent problem. Say, instead of get better, you're doing the 180 degrees opposite to create permanent problems to some degree the rest of your life. But patients don't know that. They just take their drugs, take their NSAIDs, take their medication. They don't know anything about the three phases of healing. And then they heal wrong permanently the rest of their life. That's why arthritis is the #1 disability in the United States. And so much of it could be mitigated, especially spinal, could be dampened. I'm not saying it can be taken care of 100%, but I tell you what, it'd be fantastic to see a research project of, large amounts of people with injuries that actually got chiropractic physical medicine in all three phases of healing versus drugs, all three phases of healing, and then go ahead and measure the biometrics, pain, inflammation, restrictions, tissue strength, elasticity, mobility. You'll see a huge difference in those two different, categories of therapeutic protocols. Huge, not just minor. And we know that as a practicing chiropractor. We saw this for years, this play out. Every day it plays out in a chiropractic office to some degree. Unfortunately, we typically get the patient when it's too late to some degree. So we still can help them. But again, most patients come to chiropractors when there's re-exacerbations of old injuries that are permanent to some degree. I'm like, wow, imagine if anytime people had these traumas, they got the physical medicine route in each of the three phases. How much more healthy and vibrant the society would be with mobility, being able to, and these are real issues. One of my patients couldn't pick up her 6-year-old child because of the pain and restrictions that how she healed wrong. See, these are real issues relative to quality of lifestyle. Cooking, cleaning, laundry, sleeping. There's people that have trouble sleeping and it makes their life miserable because they have problems sleeping because of these permanent problems to some degree, or they can't sleep in certain positions, or when they go into a certain position, now it wakes them up. So they don't even get their full REM sleep, and it affects their attitude and how they treat their spouse, their quality of life. All of these things just blossom into let's face it, pain and restrictions affect people's lives and relationships dramatically. That's why it's so satisfying to be a chiropractor. When you know all this, you go, wow, I'm having this kind of an impact. And then I'm going to make it affordable for the patient. I'm going to respect their time. Like, I'm having a pretty good impact. It'd be nice to have even a greater impact where the majority of people just came to chiropractors immediately after injuries, major traumas and minor traumas, instead of immediately taking the aspirin, the Motrin, the NSAIDs, the prescription medication, and then staying on of it. That's causing a permanent problem to some degree. And some of it, could be subthreshold, right? They heal permanently, but it's subthreshold. Well, go ahead and do that 5, 6, 7, 8 times and watch what happens now. All of those start adding up, and it's no longer subthreshold when you're now 30 years old or 40 years old, especially when you're 50 or 60. Those aren't subthreshold anymore. All those cumulative micro traumas that healed wrong. So they get to be very important. So anyway, okay. So physiologically, that's what we're paying a lot of attention to. That's what we're doing. We got to communicate that. We got to respect natural communication laws, defenses, resistance, paradigm shifts. We got to respect these things. And so that's what this is. That patient education is putting them all in order. It's paying attention to all of these factors. What's my problem? Can you help? Micro steps, trust, confidence, defenses and resistance, third-party biomarkers. It's putting them all in order sequentially to what the patient naturally wants. That's it. Because everybody would want that. Everybody would want physical medicine, chiropractic. If they knew this, the only main variables now are time and money. That's most of it. Well, if we could make it affordable, they'd really want it. So that wouldn't be an issue now, and we make it affordable. And then how much time did it take? That's why we spend a lot of time respecting our patient's time in all, from minimal waiting to the actual treatment itself. They got things to do. They got to take their kids to soccer. They got to go to the grocery store. So how are they going to fit this in? How are they going to fit in physical medicine, which is necessary at least 2 to 3 times a week in the repair phase to affect the piezoelectric effect, meaning the gate theory and collagen synthesis. That's what you're affecting. That's what it takes. Well, that's why we have to we got to be better communicators. We got to be more efficient with our systems so they can live their life while they're getting their treatment and restoring their health and preventing the possibility of permanent problems to some degree. So having said that, let's go ahead so those are major concepts. All right. So having said that, let's walk through the steps and apply them. But now we have to apply those. And the less effective we are at applying them, the more the patient sticks with market forces. In other words, that's all they know. As soon as I feel a little better, I'm done. I want to get on with my life. They don't understand physiologically everything that's happening and what the potential ramifications, the negative ramifications are are those long-term? So that's what this is about. So let's go into exactly how that happens. How do we do it? Why we say what we say? Why do we do what we do? It's incorporating all these factors. So it's easy to understand for the patient, makes sense to the patient. They can appreciate it. And the test is based on the biomarkers of the patient, and they're not based on the patient. If they're based on the patient, they would only base it on symptoms, and that's it. And that's one of the first symptoms. That's one of the first tests that gets better, especially in the neutral position, when all these other tests aren't. So now the patient's making a false or a false decision. They're making a decision based on fake information through ignorance. That's a large part the doctor's responsibility. So let's go into each of these categories. And okay, and by the way, this is why it works so well, because this is exactly what the patient wants to know. These are the decisions, so they can make informed decisions, and they want it to be affordable, and they want their time respected. Who wouldn't? Who wouldn't, if they knew everything I just shared with you, wouldn't want to get as much of this cleaned up as possible to minimize or decrease any potential of permanent problems to any degree, where it's totally affordable and we respected their time, where we were not invasive and disruptive of their day. They can still live their life and take their kids to soccer. Who would not pick that? Most normal, common sense people would, because that's what it is. It's common sense. Most people will not say, no, I'd rather have side effects from the medication that inhibit the healing process, that sets me up for permanent pain and restrictions to some degree with several of the activities of daily living that are important to me the rest of my life. That's not what patients would typically say at all. That's not even common sense.